Erwan Donnal will show us how to evaluate left ventricular systolic function. First, he will show us the multiple views required to evaluate the left ventricle, and then he will show us how to measure the regional and global function using the standard methods. Then he will elude the new technologies to evaluate the systolic function of the left ventricle.
We will speak about the assessment of the LV systolic function. So we have a patient that I follow for many years now for a dilated cardiomyopathy. He is optimally treated and we will assess his LV systolic function using the conventional parameters, as we will also use the new parameters that we can apply in our daily practice. So we start the exam by the parasternal long axis view. So you can see that we have here the septum, the anteroseptal wall, and the inferior-lateral wall. The dimension of these myocardial walls are quite normal. One first thing that we have to do is to measure the LV diameters in diastole and in systole. We can do that and the two-dimensional images. We will start by that. So we stop the image in end systole, and we get here the dimension in end systole that we can also do in end diastole. So we have a quite normal LV ventricle with a LV and diastolic diameter of 56 millimeter, using this 2D assessment of the LV diameters. Then we can also use the M mode or the anatomic M mode to make sure that we are perpendicular to the interventricular septum. Here we are. And we will be able to measure the LV dimension here in end diastole and in end systole. So this is the first thing that we do. We measure the LV dimension. Then we will move to the parasternal short axis view, and on this view we will be able to assess the global LV systolic function visually, and we will be also able to check for the regional function to make sure that there is no heterogeneity between each segments of the LV. Afterwards, at the end of the exam, we can also, if we want, use this parasternal short axis view to measure the radial strain and the circumferential strain, but it is not performed in the daily practice on the echo machine because it's not robust enough to be used for the daily practice. So we will focus on the apical views. So I move to the apex. I do my best to make sure that we are at the apex. So if necessary, I ask the patient to take a big breath to be sure that we are at the apex of the left ventricle. Then we get the apical 4-chamber view, the apical 2-chamber view, and the apical 3-chamber view. On this apical 3-chamber view, we have here the inferior lateral wall, the septal wall. On the apical 2-chamber view, we have the anterior wall and the inferior wall. And on this apical 4-chamber view, we have the septal wall and the anterolateral wall. Using these views, we can assess visually the LV systolic function globally, and we can also look for any kind of regional heterogeneity in LV systolic function. Then we will measure the volumes and the LV ejection fraction. Usually, we do it using the Simpson method, and I will show you. So, usually I start by the LV and systolic volume. I do my best to include the endocardium within the LV cavity. I exclude the trabeculation and the papillary muscle to optimize the LV dimension, because we know that when we use the 2D echo techniques, we usually underestimate the LV volume as compared to the MRI. So I do my best to get the best delineation of the LV contours in end systole and in end diastole. Okay, I will do the same thing on the apical two-chamber view. Sometimes it's quite difficult to get a good delineation of the anterior wall, so if necessary we can use a contrast agent to opacify the LV cavity to best delineate the endocardium. But it's not necessary in this case, so I will just show you how we can contour the endocardium in end systole and in end diastole. Here we are. So this is the manual method to get the LV ejection fraction and to get the volumes. As you can see, we have here LV ejection fraction by the Simpson method of 50%, with LV end diastolic volume of 134 and end systolic volume of 67 milliliter. We can also measure the LV ejection fraction using an automatic method with an automatic contour of the endocardium, and we will get this measurement very quickly in the four-chamber view, and we will do the same thing in the two-chamber view, excuse me. And we get an ejection fraction probably overestimated in that case, because the delineation in the two-chamber view is not completely perfect, because we miss something here. So we have to start by the manual assessment, and sometimes we can use also the automatic method, but we have to make sure that the automatic tracing of the endocardium is perfect, which is not the case here. Then we move to other parameters that we can get to best assess the LV systolic function, because we know that the LV ejection fraction is the parameter that we use to decide for many kinds of treatments, but we also know that the LV ejection fraction is highly load dependent, and also the reproducibility of this measurement is not perfect. So we will try to use other parameters that we know to be more reproducible than the LV ejection fraction. The first of them is the assessment of the longitudinal component of the LV systolic function using the pulse tissue Doppler technique. So we will use the pulse tissue Doppler, putting our sample volume at the mitral annulus, on the septal part, and on the lateral part of this mitral annulus, to get this kind of tracing of the velocities of the mitral annulus. We have here the isovolumetric contraction velocity before the opening of the aortic valve. Then we have the S' peak velocity, which is the velocity of the mitral annulus in systole. After that, we have the closure of the aortic valve and the velocity recorded in the isovolumetric relaxation time. And we have the E prime in the early diastole and the A prime in the end diastole. But as we focus on the assessment of LV systolic function, we will just report this measurement of the S prime velocity, which is a parameter of the LV systolic function and especially of the longitudinal component of this LV systolic function. So we measure this S prime velocity at the septal part of the mitral annulus as we measure it at the lateral part of the mitral annulus. The normal value is about 9 to 10 centimeters per second, and in that case, we have a value of 8 centimeters per second, which demonstrates that the patient has a mild decrease in LV systolic function. If we want to assess the longitudinal component of the LV systolic function, we can also use the M mode, as we do when we assess the right ventricular function. When we measure the TAPC, we can also measure the MAPC, and we will use the M mode to measure the excursion of the mitral annulus from diastole to systole. And here we have an excursion of the mitral annulus about 0.8 centimeter, which demonstrates a slight decrease in LV longitudinal systolic function. The other parameter that we will use is the assessment of the strain, the longitudinal strain. And nowadays, when we measure strain, usually we use the speckle tracking technique. This speckle tracking technique is a technique using the 2D images without any Doppler, just the images that we record in 2D. We will measure the LV longitudinal function using the longitudinal strain, and I want to emphasize the fact that this longitudinal strain is robust, reproducible, and we have to use it in our daily practice, thanks to the fact that it is reproducible and highly feasible in most of the patients that we see in our current practice. So to get the global longitudinal systolic function, so I mean the global longitudinal strain, we will start by the apical three-chamber view. And we have an automatic tracing of the endocardium and the epicardium. Then we will move to the apical two-chamber view, and after measuring the longitudinal strain in these three incidences, we will get these bull eyes demonstrating that we have a global longitudinal strain of minus 15, which is not so bad because the normal value is minus 20%. We can use these curves, which are the curves displaying the strain of each segment of the LV, and in that case we can see that all these curves are quite homogeneous, which is very important. It's a parameter of good prognosis because as soon as the patient has some kind of heterogeneity, this patient could be at risk of heart rate disorders or heart failure. So in this patient, the global longitudinal strain is minus 15, which is quite okay, and there is no dysynchrony, no heterogeneity, which is something very good for the prognosis. Then we have used several parameters in 2D, so we can move to the 3D. So we will change to another probe to get only one view of the LV. To get this view of the LV, we will ask the patient to stop breathing for 4 to 6 seconds to get this kind of image. We have the volume, all the volume of the LV. We have also here the RV. And we will use this volume to measure the LV ejection fraction, the LV volumes, and all the parameters that we have to measure in the assessment of a patient with a LV dysfunction. So I will just show you how to get the LV volumes and the LV ejection fraction. So we make sure that we have here the long axis, which is quite okay, and we will measure the LV and diastolic volume. Automatically, we can check that the tracking is okay. Then we will move to the LV and systolic volume. Then we will get the LV ejection fraction, 47%. We have the cardiac output, 4 liters per minute. We have the sphericity index, 0.3. And we have the LV and diastolic volume, 137 milliliter, and the end systolic volume, 72 milliliter. After that, we can use this 3D assessment of the LV to measure the LV strain in 3D, and we will get the longitudinal strain of the LV. Here we have the mean value for the whole LV, and we have here a mean value about minus 8% in 3D. Using the same acquisition, we can get the circumferential strain with a mean value here about minus 10 for a normal value about minus 20%. Then we will get the radial strain, which is the thickening of the LV in systole. Here we have a mean value about 20% for a normal value about 40%. And we can also compute another parameter of deformation, which is the area strain, which is a measurement between the circumferential strain and the longitudinal strain. And here we have a normal value about minus 15. So using this same 3D acquisition, we have the LV volumes, we have the ejection fraction, the sphericity index, we have the cardiac output, and all the components of LV strain. Just before the end of this assessment of LV systolic function, I have to use the Doppler technique to get the cardiac output using the Doppler technique. So first, I will start by the parasternal long axis view to measure the diameter of the left ventricular outflow tract. Here we are. So I can stop the image and I will measure the dimension of the LVOT. We have a diameter of 24 millimeter. Then I go to the apical 4-chamber view and I will use the pulse Doppler in the left ventricular outflow tract to get this tracing. So we have here left ventricular stroke volume of 37 milliliter per meter square. We have a cardiac output of 4.6 liters per minute on a cardiac index of 2.4 liters minute meter square. So by this way, we have assessed the LV systolic function using the 2D imaging, the 3D imaging, and the Doppler to have the assessment of dimensions, diameters, and volume, to measure the global LV systolic function by the LV ejection fraction. And also, for our daily practice, nowadays, we have to report the assessment of LV longitudinal systolic function by the tissue Doppler techniques. So we report the S prime peak velocity, and we can also report the global longitudinal strain using the 2D approach or maybe also using the 3D approach, despite the fact that the value that we get in 3D is lower than the one we have in 2D. So we might prefer the 2D approach when we report for this patient the global longitudinal strain.
So the take-home message from this examination is that we have to use the 2D derived parameters to evaluate the left ventricular systolic function. Second, we have to use contrast if the left ventricular border is not well defined. And finally, the new technologies are very promising to obtain more reproducible results in the evaluation of the left ventricular systolic function.